Ladies and gentlemen, it is my pleasure to introduce this Meet the Expert session sponsored by FMC. And we have with us Dr. Kobi Shakam, Director of the Cardiac Intensive Care Unit at the Tel Aviv Sourasky Medical Center in Israel. He has co-authored more than 100 publications in the area of acute cardiology, and he is going to debate with me the importance of urine output as a measure of kidney function and possible alert measure for kidney dysfunction. So I will ask Dr. Kobi Shakam to discuss about the importance of urine output criteria to identify AKI. As you know, we have included this in the KDIGO criteria. Whether there is a kind of trend in urine output that we can use as a somehow alert system to evaluate kidney function in the critically ill patient, and if there are electronic monitoring tools that can give us visualization of urine output trends, possibly through algorithms, and allow us to detect dynamic variation of urine output, performing somehow early measures of renal recovery prior that the patient evolves into different trajectories. So I will ask you to share your slides. I know you have a short presentation today, and I would like you to share your screen to give us the short presentation. Then we will discuss.
Okay, so thank you for the kind invitation. Well, we know, as you stated, that the KDIGO criteria defines AKI based on either changes of serum creatinine or the presence of oliguria, which persists for more than 6 hours. While the vast majority of reports on AKI were based on changes in serum creatinine because of the retrospective nature of data collection, we do know that the utilization of urine output criteria enable us to identify much more patients with AKI compared to serum creatinine criteria alone. Furthermore, when we utilize the urine output criteria, the time course for the identification of AKI is shortened significantly compared to the utilization of serum creatinine criteria itself, and is also associated with less worsening of renal function following the renal insult, and with better renal outcomes compared to patients where AKI is diagnosed wholly on changes in serum creatinine. Now, for the critically ill patients, continuous monitoring of various hemodynamic parameters such as blood pressure, pulse, saturation, and core temperature is of great importance, with the early response performed by the ICU team for alteration and changes in these parameters. Now, generally, urine output monitoring in the ICU is performed by the ICU nurses with manual emptying of the urine bag and manual charting of urinary output. The recently introduced renal sense system is a real-time sensor-based electronic monitoring of the urine output, which enable us to detect early and dynamic trends of urine output changes with possible interventions in response. The system also gives us an alarm following an observed 2 hours of oliguria. And I have a few examples of patients who were connected to this system in our ICU. As we can see here, the screen of the renal sense system, we have columns representing hourly changes in urine output, and within each column we can see squares representing 15 minutes intervals. So we can see also not only changes every hour, but changes within the hour itself. In this case, we have patients who were admitted to our ICU with sepsis and pneumonia. Following admission, we observed 2 hours of oliguria, and following the observation of oliguria and alarming us about the presence of oliguria, we performed a 300 cc fluid challenge test. And we can see that immediately following the application of fluid, there is a very nice increase in the urine output. This urine output was maintained following a maintenance of 150 cc fluid per hour for a few hours. In the same patient, few hours later, we again seen a greater decrease in the urine output, and this was associated with a decrease in mean arterial pressure from 70 to 60. Again, we intervened. We elevated the level of norepinephrine, again with nice elevation in the urine output. Another patient who was admitted to our ICU following radiofrequency ablation of atrial fibrillation, she was connected to the urine output electronic monitoring system. At the beginning, we observed relatively normal urine output, and a few hours later, again, we've seen a greater decrease in urine output resulting in oliguria. Echocardiography demonstrated congested IVC with only mild to moderate pericardial fluid without signs of tamponade. In this patient, we performed a modified furosemide challenge test, and following the application of 20 milligrams of furosemide, we observed a marked increase in urine output, which was maintained for a few hours later. So this was a positive response to the furosemide challenge test, demonstrating probably an early and reversible ADN. And the last patient is again a patient who was admitted with acute decompensated heart failure and pulmonary congestion. He has normal baseline serum creatinine. Again, this patient was oliguric for 2 to 3 hours following his admission. And again, following the applications of furosemide, we observed a very nice response with a nice elevation, which was maintained for a few hours. And this patient probably represents some kind of acute cardiorenal syndrome with response to diuretics. In a pilot study of 95 general ICU patients where we compared the identification of AKI using KDIGO criteria versus the electronic urine output monitoring in real time, we managed to demonstrate that the vast majority of patients were actually diagnosed by the utilization of the electronic urine output criteria, where only a minority were diagnosed solely on the serum creatinine criteria. I think more important, when we compared the time course for the identifications of AKI, we can see that for those patients who met both urine output criteria and serum creatinine criteria, the time course for the identifications of AKI was much shorter for patients where we applied urine output criteria represented here in the dotted circle, compared to patients when we relied on serum creatinine itself represented here in the empty square. The same was true for patients where we compared the identifications of AKI by applying either urine output electronic monitoring or serum creatinine criteria, or in the group where we compared both criteria. In a comparison study of manual urine output versus the Renaissance system in the University of Pittsburgh, published by our colleague John Kellum, nurse charting was 47 minutes late on average compared to the report by the electronic urine output system. Furthermore, oliguria was missed in 40% of the patients by the nurses and none by the sensor system, including one patient who developed AKI.
So thank you very much. I think you have shown the importance of electronic monitoring, not only for the accuracy, but also for the importance of understanding a trend. Now, my question is this. Are you thinking to create a randomized trial where you compare standard urine output measurement with electronic monitoring, and the important aspect would be to put in the protocol criteria to improve stabilization of hemodynamics, oliguria correction, and so on, so that you can prevent the occurrence of AKI episodes or need for renal replacement therapy. Something similar to what Alex Zarbok and Melanie Mersch have done, using the biomarkers as a trigger for specific KDIGO actions.
Exactly, Claudia. I think that the main point or the take-home message that we should take from our conversation is that the same things that we talk about, the biomarkers and the introduction of the subclinical AKI, which means that patients have positive biomarkers prior to the elevation of serum creatinine. I think that we need to understand that maybe it's important not to wait for actual AKI to occur with 6 hours of oliguria. But if we see 2 hours of oliguria, it is a marker that something is happening and we need to intervene. And in that way, we can prevent the kidneys to further deteriorate and for actual AKI to occur.
Do you think it would be helpful to combine in those patients in which you see a trend towards oliguria to measure urine biomarkers?
Definitely. Definitely, because I think that if in this patient we will see positive biomarkers, even without elevation of serum creatinine, elevation of cystatin or angle in the urine, it will give us a clue that something is happening. Definitely.
Of course, you need to optimize volume status in the patient, and this should be a must in order to better understand, because you know that changes in urine output are a little bit are sensitive, but a little bit less specific than creatinine and other markers of damage. So you need to study this. Have you, were you able to identify specific trajectories, like with an algorithm that is predictive?
Well, I think that what we managed to see from the cases that we have collected is that I think that the 2 hours interval is a cut point that we see. So if we see trends within the hour or within 15 minutes, this is something that can change. But if there is a continuous trend that we see that urine output is decreasing, and this is something which is maintained for more than 2 hours, it is an alarming signal that needs further intervention, or either change in the fluids, change in the level of amines that the patient is getting, and something like that.
Very short question. I saw you use the furosemide stress test in one patient. Do you think that this should be one of the procedures that is done anytime you see with the electronic monitoring a decrease in urine output?
Yeah, I think that in every patient, but especially in the patients when we observed short-term oliguria, It is a very, very simple test and give us a very rapid response, which enable to stratify the patient from those who have good renal reserve, and say that we can be much less worried about them compared to patients who do not respond to furosemide. And this is more alarming for us, and saying that we need to have some kind of other observation intervention in order to see what is happening with the kidneys.
So thank you very much. This is a very interesting technology. We had also the opportunity to test it. I think it might help in the future of monitoring of critically ill patients. And let's continue with the scientific program of the 39th International Vicenza course. Thank you very much, Professor Shakan.
Thank you very much, Professor Ronco. Bye-bye.